Welcome on into the Health Elevated podcast. We have an exciting episode for you today. We're talking with Dr. Kurt Knowlton. Let's get into it.
Dr. Kurt Knowlton is a cardiologist who has an extensive research background in atherosclerosis and coronary artery disease, and in particular has done a lot of work in helping people and defining ways to help people modify their own risk factors for atherosclerosis and coronary artery disease. Now, Dr. Knowlton, if you wouldn't mind, if you could just help us set the stage and define what specifically atherosclerosis is and what coronary artery disease is and what that means for individuals.
That'd be great, David. Thank you. This is a really important question because I think that there is some confusion in the world as to what these words mean and how to define them. And I think the better people can understand it, the more they're able to take control of their own risk factors. But a couple of things. First, to describe a little bit about what is atherosclerosis. It's also sometimes called plaque deposition, fatty deposition in the arteries of the heart, where fat deposits in the lining of arteries in the heart and in other places as well, and it causes those blood vessels to become narrowed so that the blood cannot get through them as well as they might normally do so. And it can affect the arteries that go to the heart as well as arteries that go to the brain that could cause strokes, or could affect arteries that go to the legs that could cause peripheral artery disease also. So atherosclerosis is one of the leading causes of death. As you know, heart disease is the leading cause of death in the United States. And atherosclerosis is one of the main causes of main contributors to that death rate. So when we talk about atherosclerosis, again, we're talking about that narrowing of the artery. And then when we talk about coronary artery disease, we're talking about the arteries that supply the blood and oxygen to the heart muscle. The heart is a very strong muscle that beats, in most people, around once every second for their entire life. And it's amazing that it does as well as it does, but it uses a lot of oxygen. It's the organ in the body that uses the most oxygen per its size. And so there has to be a lot of oxygen going there into these arteries called the coronary arteries. And when they get blocked, it causes a heart attack. For example, if they're completely blocked, it makes it so that the person's muscle can no longer function properly. And that's the combination of atherosclerosis in those coronary arteries. Sometimes it just makes it so they get chest pain when they are trying to exert themselves, for example, because they're not getting enough oxygen. So atherosclerosis, again, is a condition of fatty deposition and inflammation in the arteries, which can include those that go to the heart. And when it becomes severe in the heart, it can cause a big problem like heart attacks or chest pain with exertion limiting or shortness of breath and other symptoms.
Yeah, thank you. Good definitions. So I think what really stuck out to me from our introductory conversation was your vision that these diseases can be preventable, largely preventable, not for everyone, of course, but for a large number of people. Talk to us more about that. I mean, it seems like, yeah, we all kind of see heart disease as almost a final common pathway if you live long enough, but you see it differently.
Well, I do. I think that we've come a very long ways in our ability to prevent atherosclerosis and narrowing of the arteries to the heart and to the brain as well. There are a lot of things that we have learned about how to have success in doing so, but there are also a lot of misconceptions about what we can and should do in order to I think we actually have the capability to almost completely eliminate myocardial infarctions and atherosclerosis if we could pay really, really careful attention. In other words, the technology exists, the strategies exist, but getting it to the people who need it the most is often the most difficult part of this. And so, I think it's important to take some time to talk to people about how they could go about trying to dramatically reduce their risk of having significant heart disease or coronary artery disease in this particular case.
So, from a very high level perspective, what are the big risk factors, both actionable and not actionable?
Well, so the actionable, modifiable risk factors, number one on the list is smoking. There's no question that smoking increases your risk of having atherosclerotic vascular disease or cardiovascular disease. And so that's probably the one we've had a lot of success in reducing, but it's not complete yet. There are still people who smoke for a variety of different reasons, and I don't want to be critical of them and the fact that they do smoke, but it is actually one of the most modifiable and simple modifiable risk factors that exist, because when people stop smoking, the risk of atherosclerosis drops substantially. In fact, over the years since the 1970s, the risk of having a heart attack or a stroke has fallen quite a bit to about half of what it was in those days. And personally, I think a lot of that is attributable to our efforts to try to decrease and even stop smoking, which I think are laudable efforts.
That's fascinating. Quick question for you. So, with that, with smoking, so is the heart disease tied more towards the inhalation of particulates or more towards the kind of the nicotine compounds in the tobacco?
Yeah, that's a good question, and I don't know that we have a very simple answer for which it is. It doesn't seem that nicotine itself necessarily causes so much heart disease. This overlaps with vaping, for example.
Yes.
Some people say, well, if I vape, I'm just vaping nicotine. I get the same kick out of it that I get out of a cigarette, and so that's okay. And in some ways, vaping may be safer than smoking, but in reality, there's a lot of things we don't know about vaping and its effect, particularly on lung disease, which is a different subject. But I personally have a lot of concerns about that. And when children start vaping, it develops the habit of having something in their mouth that they're wanting to suck on, like a cigarette. And it remains to be seen whether that's really a helpful or beneficial habit to even try to stop smoking. I'm not an expert in that area, but I think there are a lot of questions in that regard still. We do know that, particulate matter also brings up the subject of pollution. It's pretty clear that here in Salt Lake City, we have days like today, which are kind of high pollution days because of inversions that occur a few times a year. And it's pretty clear, my colleagues have demonstrated that that can increase the risk of having a heart attack, and the admissions to the emergency rooms for heart attacks go up during these days of inversion with high pollution. And that may be inflammation, it may be the particulate matter or the inflammation caused by the particulate matter. We don't understand entirely all the processes there, but they definitely are associated. Yes.
Yeah, and the truth is probably everything contributes, but to varying degrees. Seems like that's always what I learn.
Yeah, but the one that's clearly most modifiable and easiest, most direct, it's not easy to stop smoking, but the most direct thing to help your heart is if you smoke, stop smoking. That's really one of the big things.
Yeah, I assume that secondhand smoke has a lesser but still significant impact.
Exactly. That's correct. That's correct. That's been demonstrated as well. And then
Hmm.
as we move from smoking, people, when they think about their cardiovascular risk, their thoughts go to two major things: diet and exercise. And those are important factors to consider broadly. It's clear that there are differences in cultures in the risk of heart disease, as in terms of diet, as the Japanese culture has moved to a more westernized diet, their risk of heart disease has gone up. It's clear that certain diets with large amounts of polyunsaturated fats and so on have increased risk of contributing to cardiovascular disease. So I think a healthy diet is a good thing. The one diet that repeatedly comes up as being documented to lower the risk of cardiovascular disease like atherosclerosis is the Mediterranean diet. And I recommend that people just do a search for the Mediterranean diet. It's fruits and vegetables, it's greens, it's low fat meats, fish, maybe white pork or white chicken, nuts, and in the Mediterranean includes a glass of wine, which we don't necessarily prescribe for a variety of different reasons, but nevertheless, we don't know which components are important in that Mediterranean diet, but the Mediterranean diet has been shown in several papers published in reputable journals like the New England Journal of Medicine to help reduce the risk of heart disease or atherosclerotic heart disease. So I think
Yeah.
diet can make a difference.
Yeah, the Mediterranean diet comes up in almost most chronic disease. I think it's interesting. I just wanted to, and a question that I've always had. So it seems like when people isolate down to the Mediterranean diet, a lot of times they're looking at, the impacts of that overall culture. And my understanding is that culture has a much deeper community and stress-free approach to life. A lot of those cultures do that have practiced the Mediterranean diet. Is if are the studies that you've looked at, have those specifically isolated the diet, the Mediterranean diet, and so it's not a compound effect of the overall lifestyle?
Yeah, they actually have, David. That's a really important point. There's always the question of association versus cause and effect. And a randomized trial can help address that. And so there have been more than one randomized trials that have been done in American culture where they put people on a Mediterranean diet versus a different diet. In fact, a couple different diets in some cases. And the one that most consistently comes up as being beneficial for the heart is when people are randomized to a Mediterranean diet. Now, nutritional studies are difficult. There's no question, but these studies have been done in fairly rigorous ways, enough so that they were published in the New England Journal of Medicine because of the beneficial effects that we're seeing even in American culture.
Yeah, I've seen similar studies, look at the affection of neurodegenerative disease, and they're very interesting. Yeah. Now with that, what's the time frame for that? I mean, if you start practicing the Mediterranean diet, can you expect to see your risk of atherosclerosis go down over the next, several weeks, or is this something that you need to practice, over, several years to see the impact?
Well, as I recall, the studies are over a period of a few years. I wouldn't expect to see miraculous changes in a very, very short period of time, as in a few months. But over a few years, yes, that we should be able to expect to see some benefit in that regard. Yes.
Yeah, I mean, it makes sense, and it takes many years of a bad diet to put you in a disease state. Yeah.
I think it's just a matter of establishing a habit of what you eat, a new habit. We in my family, we always loved our Sunday dinner of mashed potatoes and gravy made out of the fat from the roast beef that was cooked and enjoying the roast beef. And that was all really good. We loved that. But on the other hand, that's probably wasn't the most cardiovascularly safe diet. And so changing that and changing our culture in terms of what we eat in those situations can help modify that.
Hmm. Interesting. And earlier you alluded to, but we always combine diet and exercise. Specifically, I mean, talking about the types of exercise or, what the effect of exercise would be.
Right. So study after study show that people do better when they exercise than if they don't exercise. Those have some bias with them because obviously healthier people exercise more than unhealthy people. But as people try to tease that out, it's pretty clear that exercise has beneficial effects. If we try to pinpoint what those beneficial effects are, it clearly can have be advantageous for our weight, for example, and our disposition toward diabetes, and which can be a risk factor for heart disease, and so on. So those are two of the big things, and just being active helps us to think of other healthy things as well. But that's more my perspective than documented in data and analysis. But it's pretty clear that those who are active and exercising do better. You get better exercise, that muscle of the heart that we talked about earlier. When you do cardiovascular exercises, it does exercise the heart. Now, I think that there are benefits probably from more weightlifting kinds of diet exercises as well, but um, and that helps the heart also. Just in general, being active is going to be good for you. The American Heart Association recommends 5 days a week of about 30 minutes of exercise, or 3 days a week of vigorous exercise, like jogging for moderately long distances. So that's what the American Heart Association recommends in terms of cardiovascular or cardiac workouts that people might be doing um, along those lines.
My my own intuition and reading suggests that there's probably a difference between deliberate exercise and an active lifestyle. Would you recommend, that people try to be very deliberate or conscientious about setting aside time to exercise, and similar to the American Heart Association recommendations, or more encourage people to change a lifestyle to be more active? I mean, what do you find to be a better recommendation, or perhaps just more sustainable for patients?
I would say both. I'd say both are important. For example, the statement is often made, do you park as close to the door when you go shopping as you possibly can, or do you park at the other end of the parking lot so you can get some exercise walking to the store? Do you climb the stairs or take the elevator all the time, or the escalator? Those are all, things that contribute to a more active lifestyle. But the truth of the matter is, with the growing technologies, the majority of people tend to lead more inactive lifestyles. And I think that most people can benefit from some degree of active, purposeful exercise. To tell you the truth, I'm not. I'm personally don't think we're talking about running or participating in triathlons or running marathons necessarily. There's some debate exactly, what their effects are on the heart. But I encourage my patients to at least get out and go for a walk. I don't think we have to exhaust ourselves, although if you really want to get in better shape, that helps. But for your heart, I think just getting out and walking briskly, biking, exercise bike, indoor exercise bike, swimming, other types of cardiometabolic exercises are uh, generally tend to make people do better overall. It affects their mindset, their weight, and their diet and other things as well.
Yeah. Yeah, and it's interesting. So you've hit the big 3: smoking, diet, and exercise. And I like to think of the body as a system, and all the different components are linked together. Seems like if your heart's in bad shape, your brain's gonna be in bad shape. If your liver's in bad shape, your heart's not gonna be doing well. And these 3 big factors you've already mentioned, these are the great regulators for pretty much any system. Stopping smoking, don't smoke if you're already not smoking, and having a proper diet and an active lifestyle with deliberate exercise. That's interesting that those are the 3 you bring up first. What other modifiable risk factors have you found?
Well, so I'm gonna um, there are other modifiable risk factors, which I'll get to in just a minute because they're related to what I'm going to call a non-modifiable risk factor next, and that is your genetics. Um, so I use the term non-modifiable because you can't get rid of it. Like, you can stop smoking, but you can't cut out your bad genetics, at least not yet. And the reason I bring that up as an important point is I think we've done a pretty good job of helping people understand the importance of diet and exercise and not smoking. Some people choose not to change their lifestyles, but I think most people would recognize those as modifiable risk factors. But genetics is probably one of the big ones that we need to think more about. And because there clearly are populations of patients who are much higher risk of having a heart attack or a stroke than are than another group of patients who seem to have better genetics. And we don't completely understand what the differences are, but we do understand some of the differences that exist. And I'll try to point out a few of those if I can, and lead into the some of the next discussion, because this is where I'm not convinced that we've done a great job at helping people understand how important it is that they know their numbers. We sometimes say, know your numbers. And I'll talk a little bit about what those are. For example, do you know what your cholesterol is? And the reason that ties into genetics is At one extreme end, there are people who have very, very high cholesterol, and they have heart attacks. There actually are people, there are children who have heart attacks at age 9. That's rare. That's not, the big population thing we're talking about, but there are people, there's a scale of people, or a line of people, that range from extremely severe risk to no risk. And one of the markers of that risk is your cholesterol or your lipid levels, which are the fatty molecules in your body. And the one that's easy to remember, easy for me at least, is the low density lipoprotein, or LDL, which is your bad cholesterol. And if that bad cholesterol is quite elevated, we have ways to treat that. We have a lot of ways to treat that now and bring that down to a very normal or low risk profile. So that's one of those genetic contributors. And it doesn't have to be as bad as the person who has a heart attack at age 9. It could be a family history of, people in their 50s having heart attacks in your family, for example. And sometimes we don't even recognize it. And that's where the cholesterol level can really help, because that's a measurement you can make and you can say, whoa, that's higher than I thought it would be. I maybe need to pay attention to this. Another is high blood pressure. Another number, do you know your high blood pressure, your blood pressure measurements? Because high blood pressure is clearly a risk for having heart attacks as well as strokes, a major risk for having strokes. The other is, for example, your blood sugar. Do you know whether you have diabetes or not? Because that is also a significant risk factor for heart disease. So if we start thinking about numbers, there aren't that many that are crucial. Maybe, is your kidney working okay, is important. But the three big ones probably are your cholesterol, or your fatty levels, fatty molecules in your blood that go on to contribute to the atherosclerosis, hypertension, high blood pressure, and diabetes mellitus are three of the big ones. And we have great ways of treating all three of those now. It's a shame that people walk through their lives either not wanting to know about it because they don't really want to take any medicines, or not knowing about it because they never get a chance to see someone who will measure that for them.
I'm really it makes me really happy to hear you talk about the non-modifiable risk factors, the things that lead to, cholesterol, fatty acid levels, and hypertension and diabetes. Years ago, I took a class from Dr. Lynn Jordy at the University of Utah about genes and complex disease. And the biggest thing that I took away from that class was that no disease exists in isolation. No disease is inevitable despite how heritable it is. And in fact, I remember one instance in the class discussing, heritability, and Dr. Jordy made the point that nothing is completely heritable. And someone brought up, well, what about gender? And even gender is not heritable necessarily. It's not totally dependent on your genes. And I just remember just being shocked by that and coming away and realizing so much, where we thought, I used to think of, your genetics as predestining you for an outcome, but it's not the case at all. Genes interact with your environment in powerful ways. And in this case, you're arguing that, genes can lead to certain phenotypes, high blood pressure, for example, but that can be modified. And then the effects of that phenotype can, in fact, not be a contributing factor. And I guess in many ways, I find that particularly empowering that, we can rise above our genetic risk factors by controlling our environment and by managing our health through those regular checkups, knowing your numbers, as you say. So that's pretty empowering.
And I agree with you. Sometimes we think, well, it's genetics. I can't do anything about it. I was born that way. I didn't choose who my parents were going to be, but I've got this risk factor. But in fact, you can do something about it. And I'm going to introduce, a concept that sometimes is a little bit more controversial. There certainly are things in your lifestyle that you can do to modify your lipids, modify blood pressure, and modify your risk of developing diabetes. Watching your weight is one of the big ones. Modifying your diet is a big one. But I have to say that there are also uh, medications that are very low risk that are excellent at modifying those risk factors, probably better than most people are at modifying their environmental factors as well. So I often will, when I see a patient, they'll often tell me, I don't really want to take any medications. I want to see if I can modify my blood pressure by myself. Well, if it's not too high, I always, the patient always makes the decision. But if it's not too high, say, okay, you be careful with salt intake. You need to lose weight. You need to exercise more. Those will help your blood pressure. But usually they come back and they've tried and they've had some success, but they've not reached what would be an acceptable risk and or acceptable blood pressure from the risk perspective. And I think it's just important to recognize that there are medications that have clearly been able to reduce the risk of a heart attack or a stroke when a person has high blood pressure. The same thing can be said of high cholesterol. People often want to try to modify it themselves. I say, great, that's wonderful. And even some will say, I'm going to go on a vegan diet. That's great. It will probably improve your cholesterol, but it's very, very hard to live with. Some people can, but many cannot. And so it's worth remembering that there are excellent therapies that come in the way of medications that can really help lower, not just lower the LDL or the cholesterol, but can actually lower their risk of having a heart attack, lower their risk of having a stroke. That's what matters. It's not the cholesterol that matters, except it's the causing agent. It's the fact that a person would go on to have a heart attack or a stroke that really matters. And I think that's the controversial part in some regards, because people, in some ways, don't want to introduce foreign substances into their body, but they're already are trending toward a disease that they don't want to have. And if they could recognize how easy it could be to try to modify that risk factor, I think we could have a major impact on dramatically reducing, say, atherosclerosis, for example, or heart attack or stroke, which are really what we're after.
Wow. Well, Dr. Knowlton, you changed my perspective on heart disease. I'd always heard and seen the numbers saying that heart disease in general is it's the number one killer in the United States, and seeing the numbers on atherosclerosis and thinking that I hadn't really put together the concepts of how preventable it potentially is by through modifiable risk factors. And this has been a very, very intriguing conversation. Very grateful for your time. I have one final question for you. If you could, put together a message, like about 1 minute to say to to all of our listeners about what they can do in their individual lives to really reduce their risk of atherosclerosis, reduce their risk of coronary artery disease, and by so doing, reduce their risk of myocardial infarction or a heart attack. What would you tell people?
I would tell them, number one, like they're trying to do, live a healthy lifestyle. That's number one. Number two is try to determine as best they can by knowing their numbers, whether they're in a higher risk group for having a heart attack or a stroke or in a low risk group. If they're in the higher risk group, that's when, and the physician can help you, a care provider, physician, or advanced practice provider can help you to determine that. Then, if you're in the higher risk group, being aggressive, not only with lifestyle modification, but also taking advantage of the discoveries that have been made that can really help reduce the risk through medical management of those diseases as well. That would be my message.
Wonderful. Dr. Knowlton, I know your time is very valuable, and we're very grateful that you were able to join us and share some of your findings and insights into preventable heart disease. Hope everyone else finds it equally valuable, and thank everyone for tuning in.
Thank you. Thank you very much, David. It's a great conversation.